I was just actually had a question. How many people in the room have already given birth before? Okay. How many want to give birth one day? Awesome. I'm so glad you're here. This is great. And how many people have attended a birth or been a care advocate for someone? Okay, so most people in this room pretty much understand, what we're trying to get at here, right? That's why you're here, which is awesome. But I wanted to talk a little bit about the power of informed consent and having a care advocate. So when it comes to birth, a lot of women basically just depend on their gynecologist, and this is what we've been talking about all day, right? So I'm not gonna, keep on harping on that, but I did want to talk a little bit about the importance of a birth plan and a care advocate. So I want to talk a little bit about my story. I had a doula, and we created a birth plan, and I was supposed to give birth at a birth center, right? So one of the things that we need to be asking ourselves is, what questions should we be asking when it comes to giving birth? Not, giving just the answers to these questions. So at Mothers-to-Be, we have a birth plan on our website that you can find, you can download, you can customize it. And one of the big things that we really want to focus on is if you want to have a birth in a hospital setting, if you want to give birth at a birth center, if you want to give birth at your home, having a care advocate who knows your plan is the most important thing you can do to set yourself up for success. So whenever you're moving forward, and I'm sure if you're a birth provider, you know this, someone who has a doula, or is it your partner, is that your husband, whoever it is that is with you, needs to know the plan. And so that's why I'm not going to get into all the nitty-gritty details, but if you want to find a birth plan, we have one on our website, and that can actually start with what questions should we be asking whenever we're giving birth, because the sovereignty of the mother is something that I think is left out a lot in our care. The mother should be making decisions in an informed manner, and that is not happening, especially in emergency situations. So at Mothers-to-Be, we take the stance that even in emergencies, it could be really great and should be the standard of care that we should still give 10 seconds, right? Hey, this is what we might do. Do you want to do this or not, right? Instead of just treating the mother as a patient and letting things happen to her, we want to have her active in the decision-making process, even through labor. And that's why it's important that the mother and the father, or the care advocate, be that a doula, is on the same page about what she wants. And really kind of going through these scenarios, right? Like, one of the things that I had no idea about whenever I gave birth was, I didn't have it on my birth plan either, was placenta delivery, right? So I didn't make a specific note, hey, I want to birth my placenta naturally. And I will spare you the details, but that did not end up very enjoyable for me in those moments. And I think that's where we really have to start, helping mothers finding out what questions we should be asking, right? How should you birth your placenta? Do you want Pitocin? Do you know the side effects of Pitocin? Explaining the cascades of interventions. And I personally take the stance that if you want to do these different interventions, that's your decision as a mother. And as long as the mother's sovereignty is respected, I think that can keep us moving forward in the right direction.
Wow, okay. So let's talk about doulas first. Many hospitals are starting to have doula programs, and some people are applauding that, but I would tell you that that's a problem, because doulas who work for a hospital have a conflicted fiduciary duty. Right? The hospital is going to tell them that they, you can't tell them things that are really their right to know, because the hospital policy doesn't let them. So if you're going to look for a traditional advocate, which I truly believe that we need, you need to have something that's independent. Mm-hmm. You also need to have someone that knows your plan really well, because women are mammals, and they labor best when they're undisturbed. And they don't need to be trying to be coerced or bullied or something. That should all be done ahead of time. And that's a problem, because a lot of times when you come into a hospital setting these days, you have no idea who's going to be taking care of you. You may have a physician that you've been seeing the entire pregnancy, but he's in a group of 7 doctors, and they got 1 in 7 chance of that person not being on call. So you need to, when you're checking out an OB, I always tell women nowadays, I'm not practicing anymore, but I tell women nowadays, when you go to your first OB visit, remember, you're the boss. You're going there to interview them. Don't let them take your blood pressure. Don't let them draw blood. Don't sign any forms. You're going there as an interview. And you're going to ask them, what happens if I go past 41 weeks? Can my doula and husband be in the room at the same time? Can I leave the delayed cord clamping for more than 60 seconds? You ask these questions ahead of time and see how they look at you. Do they give you the time of day? Are they rolling their eyes? Are they have one foot in the door to get out the door? Because the medicalized birth model, unfortunately, works on volume. And doctors need to see a lot of people because, and I'm going to get off topic by talking about reimbursement, so I won't go there. But they have to do volume, whereas the midwifery model isn't about making money. Most midwives know that. They're not going to make much money. But their prenatal visits are an hour long. And so there's a real difference in the model of care. And when you move into a new community, just like you check out where's the Costco, where's the schools, what kind of facilities do they have, check out your hospitals. Before you move into a community or when you get to a community, check them out. Understand that if you want to be informed, you want to know what's going on in your community. And when you have, by the way, to get informed consent, to give informed consent, you have to be informed. And today, the problem is that the medical model is based in fear. And so the information, because ACOG itself says pregnancy itself is a high-risk condition. And if this is the prism by which obstetricians are trained, and the companies they work for manage them, then this is how they're going to see everything, and they're going to skew their consent to funnel you down the path they want you to take. So informed consent is a lovely statement, but it doesn't matter if the information you're getting is skewed. So you really have to know that. And doctors also don't understand what high risk really means, because the medical model of care looks at pregnancy as a high risk condition, and it looks at that doctors hate chaos and they want to manage it. And so they look at all pregnancies as something to be managed. Whereas the midwifery model, as I learned over the years of working with midwives, is that they trust that birth is a normal function of a woman's body, that it's designed to do this, and occasionally it will go wrong, but midwives are willing to accept uncertainty. Doctors tend to not accept uncertainty. And what do I mean by high risk not really being a number? Well, it isn't, because some of the things they'll tell you are high risk are less risky than the things they want to do to intervene upon the thing that's high risk. For instance, you talked about raw milk. Yeah. They'll tell you not to drink raw milk, but ACOG recommends 4 vaccines while you're pregnant. All right? Raw milk is high risk. 4 vaccines, never been tested for safety in a randomized placebo-controlled trial in anyone, let alone pregnant women and fetuses, is okay. Or you're over 35. That labels you as high risk. So what do they want to do when you're over 35? They want to induce you. So which carries more risk, being over 35 or having a labor induction? Everybody? Labor induction. But which one's labeled high risk? Being over 35. So, right. So it's about fear, and they're permeated with fear, and that's where we have to change the system. We'll probably get to that in a later question. But advocacy is really important, informed consent. You have the right to information on everything. No one's allowed to touch your body without your permission. And if they use coercion, by the way, that same organization, ACOG, who they follow, like a puppy dog following its mother, doctors follow that, have guidelines about ethics that say that use of coercion, including the risk of the use of calling child protective services, is never acceptable. And yet people are threatened with that all the time.
So this actually segues nicely. I'd like to ask Sally a question, because Sally talks about dietocrats, and there's a fear-mongering and fear basis that prevents a lot of women from actually nourishing themselves the way they need to be nourished to have an optimal pregnancy. So Sally, your work obviously at the Weston Price Foundation emphasizes the critical role of nutrient-dense diets, rich in fat-soluble vitamins for both parents before conception and through pregnancy and childhood. Can you explain a little bit why this traditional dietary approach is so vital for optimizing maternal and child health outcomes, and how it empowers women to make informed choices for their families' well-being during the perinatal period and beyond? And if you want to say a little bit about what you may think is preventing more women from doing this in the work of the Weston Price Foundation and actually facilitating better connections.
Thank you very much, and thank you for having me. So just a little bit of explanation. Dr. Weston Price was actually a dentist, and during the 1930s, he traveled throughout the globe to study healthy, what he called primitive people. And by healthy, he meant they had naturally straight teeth, broad faces, ease of reproduction. When you have the broad face, you have the round pelvic opening, so childbirth is much easier. And they were just healthy in every way. And he wanted to know what kind of diet supported this good health. And he had a laboratory, he tested all these foods, and basically the answer comes down to nutrient density. These diets were very high in minerals and extremely high in what we call the fat-soluble activators, or the fat-soluble vitamins, 10 times greater in the traditional diet than in the modern diet of his day. And these vitamins are vitamins A, D, and K2. So where did they get these vitamins? They got them from animal fats. They got them from organ meats. They got them from fresh and fermented raw milk. They got them from seafood. Fish eggs were highly prized for fertility. A very important fertility food was liver, which we have a hard time eating these days. Anyway, all of these foods, butter from grass-fed cows was another fertility food. And all of these foods are demonized, right? High cholesterol, high fat, don't eat vitamin A, it's going to be bad for you. So what modern medicine, modern thinking has done is demonize the very foods the traditional people valued and revered for good health and especially for fertility. So we advocate a nutrient-dense diet at least 6 months before conception, and a lot of these problems that we're hearing about just clear up with this diet, including things like endometriosis and infertility. Our diet includes a quart of whole milk from grass-fed cows per day, 4 tablespoons of grass-fed butter, 2 to 3 eggs, liver a couple times a week, especially poultry liver, fish eggs if you can get them, and no processed foods. And we have had, I would say, thousands of babies born to this diet. Not only does it make for ease of conception and pregnancy, but these babies are absolutely beautiful. I want to say a couple of things about vitamin A, and then I'll stop, okay? So vitamin A has been demonized by one really bad dietary recall study that's contradicted by all the other studies on vitamin A. You cannot make sex hormones or thyroid hormones without vitamin A. And we're talking about true vitamin A now, we're not talking about carotenes. So that's number one reason why it's so essential for reproduction. Number 2, when reproduction occurs, the first thing that happens is an embryo forms. And the cells in the embryo are stem cells. They're undifferentiated cells. And they start to get signals. This signal says you're going to be a heart cell. The heart is the first organ to form. You're going to be a brain cell. You're going to be bone cell, and so forth. What gives the signal? It's vitamin A. Vitamin A is the concert master of fetal development. So even if you can get pregnant on what you're eating now, if you haven't built up your vitamin A stores like the traditional people did for 6 months, you're not going to be able to hold that pregnancy. So I can't stress enough, you just cannot build a baby without vitamin A. And finally, the last thing I want to say is something we're very concerned about is people taking a lot of vitamin D. Because vitamin A and vitamin D and vitamin K, they all work together. Sometimes people take vitamin D and vitamin K together. This is the fastest way I know of to deplete your vitamin A stores. And it can definitely lead to infertility. You want to get your vitamin A and vitamin D and vitamin K in foods. They're usually in the same foods. We recommend cod liver oil for so you get the A and D together. And you don't need that much vitamin D. You don't need 10,000 units of vitamin D. It's just a way overload. And then you get your vitamin K. The best sources are poultry liver and butter fat. So that's our prescription. Thank you.
Thank you so much, Sally. Kelly, I'm going to move on. I think that we've spent a lot of time today talking about kind of restoring fertility and that being a sort of an optimal approach to becoming pregnant and sustaining a healthy pregnancy and having a beautiful birth. So Kelly, I kind of want to just turn a little bit to some sort of more ethical questions that come up. The Center for Bioethics and Culture, where you're the executive director, highlights the lack of longitudinal research on surrogate mothers and children born through assisted reproductive technologies. Could you share with us a little bit more about the existing research or personal stories that reveal about the experiences of women and why you believe there's such a significant gap in comprehensive data on these practices to date?
For sure, and I really appreciate being a voice here and kind of a little bit different side of things, because I think here we're focused on restoring fertility for women or couples, but I'm here kind of as a voice to women and children in this sphere of technology, reproductive technology specifically. And this is a space, I believe, where the health and well-being of women who freeze their eggs, women who sell their eggs or donate their eggs, surrogate mothers, and the children born of these technologies are being systematically overlooked in current policy frameworks and in our healthcare. So I really appreciate being able to speak on their behalf and share some of the stories. The little studies that we do have, independent research that we do have, and the countless personal stories that we hear in the work of the Center for Bioethics and Culture paint a really dismal or concerning picture of the long-term impacts of assisted reproductive technology, particularly for egg donors, and I use that in quotes because these women do sell their eggs, they don't donate them, surrogate mothers, and the children, again, who are born from these technologies. We know, and we've heard today, that there is a vital connection between a child and his or her biological parents, but there is also an integral and an indispensable connection between a child and the mother that carries him or her. So first, I'd like to talk about surrogate mothers and what we know there. A study most recently in 2024 showed a higher risk for severe maternal morbidity in surrogate pregnancies and adverse pregnancy outcomes for surrogate mothers. Studies have shown collectively that surrogate pregnancies are at higher risk for preeclampsia, gestational diabetes, postpartum hemorrhage or hemorrhage during delivery, and placental abnormalities. I did my own research into this where I interviewed over 96 women in the United States who are surrogate mothers as well, and our studies also kind of confirm this high-risk nature of surrogate pregnancies. After a very emotional and physically taxing process of hormones, hormone therapy, and multiple embryo transfers often, these women are much more likely then to deliver via C-section, sometimes 3 or 4 times more likely to deliver preterm, and are more likely to go home with postpartum depression. After delivery, some of the women that I personally spoke to, and I'm thinking of a woman, and I'll share her story in a moment, but they talk about the emotional trauma, particularly when they bond with the child that they're carrying, and they weren't prepared for that because the language of the fertility industry is very manipulative in that way. I recently interviewed Erica, and her interview can be found on YouTube, as most of my interviews with surrogate mothers. And in her contract, she was to have a little bit of contact with the baby right after birth before the intended parents were to take that baby away. But as the baby was being delivered, they grabbed the baby, and medical professionals started yelling, "No contact, no contact, no photos." She was denied time with that child, and more importantly, that child was ripped away from the only home that child's ever known. And so we're talking about the influence of this connection, this in utero connection and pre-pregnancy. I'm getting beside myself because I want to talk about that in a second. But if this surrogate mother does develop any complications during her pregnancy, let's say preeclampsia, which Erica in this story did also develop preeclampsia, those long-term effects don't end when the baby is born. They will follow her for the rest of her life, probably causing chronic health complications later. And to kind of tie that in a bow, preeclampsia, which is a common complication of assisted reproductive technologies, is on the rise in the United States. And if you have preeclampsia in pregnancy or childbirth, you have a future risk factor for kidney disease, stroke, and cardiovascular disease later in life. We know in the United States that cardiovascular disease, which includes heart disease, is the #1 killer of women. So if we put all of this together and go full circle, we can see that there's a dangerously unhealthy cycle for women who are utilizing assisted reproductive technologies or who are being used by these technologies in the case of surrogate mothers. So I'd like to focus just for a second then on that child. This child is created in a lab and it undergoes the stresses of pipetting and other environmental stresses. She or he is carried by one woman and then handed over to another family. And like I said, we know that maternal bonding begins in utero, that a mother's voice, her heartbeat, her emotions, her nutrition, all have a huge impact on fetal development from the very beginning. This child knows that surrogate mother on a primal level, and to dismiss this connection is to dismiss basic biology and human experience. There's a big emotional toll on donor-conceived individuals. I've talked to many of them who talk about the loss of identity, the loss of medical records, and just the emotional part of it. But there's also, we're starting to see now, thankfully, some research in this space that there are health concerns for babies who are born through assisted reproductive technologies. And I'd like to name just a few, but premature birth, low birth weight, developmental or medical concerns like ADHD, cerebral palsy, imprinting disorder, heart defects, high blood pressure, insulin resistance we talked about, congenital malformations, and that's just to name a few. I could go on there. And for the sake of time, I won't include egg donors in this conversation, although I'd like to, because they are such an important part of this conversation, because they are completely lost in medical history. We have no long-term data for these women who might go on to develop hormonal imbalances, a loss of their own fertility, and even cancer later in life. They are completely lost in medical history, and they deserve, again, truly informed consent, which they can't, they're told there are no known long-term risks, and they take that to mean that there are no long-term risks at all, and that's just not accurate. And then I'll answer your question, why is there a gap in this coverage? And the answer is really simple, and it's really uncomfortable, that we have allowed commercial interest to override ethical responsibility. I think if the fertility industry did the research, they'd see the harm and then they'd have to stop profiting.
Thank you so much. It's such difficult stories to tell, but thank you so much for doing so. I don't think most people are aware of just how painful that experience is. And it's so, I feel really humbled by everyone's contributions to presenting today really beautiful, strong options for returning to people what they rightly should have, which is really good health and fertility and life force and creative capacities. And so thank you so much for sharing that. I'm going to move in, just because it's a really nice kind of segue from here, to Stu, just to talk, if you want, a little bit to talk about this, I think what you've talked about a lot, treating birth as a medical emergency. And you argue that the profit-driven, intervention-heavy obstetric model undermines natural birth. What thoughts do you have for addressing the systemic coercion and financial incentives in maternity care to ensure that informed consent and is honored, and to prioritize these non-interventionist approaches, especially when complications arise?
There's a lot of forces involved, obviously, and you just mentioned one of them is the financial force. The system is set up to feed a lot of different animals. And, the hospital, the insurance companies, the the specialists, everybody's making money and the outcomes are not getting better. And hospitals, the people, I don't know if it's the PR departments that are just wacko or what, but recently they had a thing where everybody was trying to be mother-baby friendly. You've heard the term mother-baby friendly. It's like the good housekeeping seal of approval. And hospitals tried to get this mother-baby friendly thing, and then COVID came along and they threw it immediately out the window. So mother-baby friendly meant that, you know, that people could come and babies would, yeah. So it was thrown out the window. So it was really all virtue signaling. But before that, there was another slogan about 10, 15 years ago that said, let's make hospitals more home-like. Because they wanted to compete with home birth, which is on the rise, by the way, went up about 30 or 40% over the last couple of years, which isn't a lot when it goes from 1% to 1.4%, but it's still 40%, so that's math. But making hospitals more home-like. So what does that mean to people that work in the hospital? Well, let's put hardwood floors and curtains in there. Right. That's what they did. But they didn't change any of the policies. The women still had to be on their back, they still had to be monitored, they still could only have a popsicle if they were lucky, and all the things that hospitals do that are sort of wrong, just plain wrong. But they're financially motivated. Because you know what? There's no RVS code to bill for not starting an IV. There's no RVS code to bill for not drawing blood on admission. Why does a woman need blood on admission? When we go to the home birth, we don't draw blood on admission. And by the way, when you go to the hospital that they're trying to make more home-like, what's the center of every labor room? The bed. If you ever been to a home birth, how many of you have been to a home birth? I like that idea, Claire. It's great to ask. Right. If you walk into a home birth quietly when a woman is in active labor, how often is she in her bed? Never. Okay? So this is how they think. So we have to change that, and the way to change that is to bring back midwifery, not the medicalized midwifery that's happening now with NARM and NMI. They're getting medicalized. They're not using the word woman anymore. These crazy things that are happening in our academia. But to bring in traditional midwives and help them teach. And ultimately, I think to solve the problem, we need to do, as a lot of you talked about earlier today, we need to get to our teens. We need to get in middle school and high school, not only to talk about your bodies, but also to talk about pregnancy, to teach the boys and the girls about that birth is normal. To teach them that this is a normal process of the body, that when left to the primitive brain and get the cognitive brain out of the room, it usually goes smoothly most of the time. And then for those rare cases where we need something, we have the specialists in the hospitals. The problem is the way the system is set up is that if the hospitals don't take all the normal pregnant women and medicalize them, they can't afford to stay open. They can't afford to just stay open. So their hospitals, like a lot of hospitals now are closing in rural areas simply because they can't meet the guidelines that are being put out. So what does that do? A woman now has to drive 100 miles. How is that safer? So safety is not one definition. If I asked everyone in this room the definition of safety, I would get 100 different answers. Because some people feel safer in the hospital. But that's maybe because they've been sort of brainwashed to believe that the hospital has their best interest at heart. But it doesn't always have their best interest at heart. As a matter of fact, with the shift mentality, you may get to like the nurse that's taking care of you, and suddenly there's a change of shift. And when you have safety in the hospital, they think, well, I've got an operating room down the hall. Well, let me ask about that. Do you think that if there's suddenly a disaster, like a placental abruption that occurs, first of all, there's probably nobody in the room with you when it happens. You're on a monitor that maybe somebody's watching from the desk or maybe they're not. And somebody comes in and they say, oh, we need to do a crash C-section. How long is it going to take, even in a hospital? You've got to have an OR crew available, you have to have an anesthesiologist available, you have to have a surgeon available. The OB's probably at home, or there's maybe a hospitalist now and he's there, but you have to have an assistant available. To get all that done, maybe you could do it in 10, 15, 20 minutes. If a baby is really in that much trouble, you don't have that much time. So you're not saving anything, but you're changing the way birth is supposed to be managed, which is to be safe, quiet, and unobserved. And the home setting is a much better place. So we need to get to our teens, and one other thing we need to do, besides getting people out of the hospital, as Marcin Wagner says, and business of being born is if you want a safe birth, get the hell out of the hospital, is change the way we reimburse. And this is a big issue, and I don't have any control over that.
Yeah.
But it takes more skill to be to do a vaginal delivery, more time, and yet it gets paid less. The hospital makes more money, probably 2 to 2.5 times as much money by a cesarean section. So what is the incentive of the chief financial officer of the hospital to lower the cesarean section rate of their hospital? Their fiduciary duty isn't to the woman, it's to the hospital and to the board of directors and to the stockholders. It's a complete corrupt mess.
I just wanted to jump in there real quick too about birth centers and midwives, right? So all midwives are not gonna. One midwife to another midwife is not going to be the same, right?
That's
so
right.
When you're shopping for a midwife, if you're thinking, okay, I don't want to give birth in a hospital, don't assume just because she's a midwife, she's on the same page as you.
Can I speak to this?
Yes,
Yes.
Adelaide, we have a
You
non-traditional,
take us home, Adelaide.
non-medical
Take it
midwife in the room. Adelaide Meadow, can you tell us all about your experience as a midwife and talk a little bit about the distinction?
So, first of all, I love that this conversation is even happening, right? I'm here as a lay, unlicensed home birth midwife, and that this is happening at a national level, that we're able to have this conversation. And just to discuss sort of some things that Dr. Stu was previously bringing up, like our hospitals and our system is failing our women on such a broad level that what we've largely created is often women who have the least amount of resources and in many ways less training than other of my medical colleagues are caring for some of the most high-risk patients. And I just want to identify how and why this is happening. So I think naming the problem, that's what we're doing a really good job here, is we're naming these problems and trying to think of upstream solutions. And one of the issues that is really unfolding here is if we're limiting what our physicians can do, both because of the compensation model, which obviously that's an ethical concern, right? But also because of the training model, which that also might be a compensation model, also maybe another ethical concern, right? Then what's happening is we have the doctors in the hospital that aren't attending breech, they're not attending twins, they're not attending post-dates, they're not attending VBAC, right? And then we have, I will sort of stay out of the licensure midwifery conversation for the sake of this, because ultimately, I'm not actually that concerned about licensure, I'm far more concerned about skill. Because what then occurs is these skills we're actually de-skilling broadly our birthing assistant population. And that de-skilling, which is largely what we're talking about more broadly in women's health, we're not understanding the restorative reproductive model. Our physicians are de-skilled. We're not understanding our nutritional model. All our nutritional providers are often de-skilled. And this is true as well that's happening on the level of who's actually attending births. So then for me, as I've been building my skills over the years, right, now I'm attending a breech mom. Now I'm attending a mom who's 42 plus. Now I'm attending 42 weeks plus. Now I'm attending a mom who's also, 42 plus. Now I'm attending a mom, who potentially, I haven't actually attended multiples at home, but these are the women that aren't, or a VBAC mom, that aren't able to access this care in the hospital. And often the midwifery licensure is prohibiting those licensed midwives, should they even exist in her state, from legally attending that woman as well. So now we've created a scenario where potentially a mom who has maybe has a breech baby, is maybe 42 and has a history of C-section, someone where we might actually utilize some medical metrics potentially, right? That mom now often doesn't have access to that, and so she would end up in my care, right, at home, which I will say, I've attended all of those situations. These babies are all happy and well in this non-medicalized birth environment. That being said, that collaboration is just entirely de-incentivized, and I would argue in many circumstances criminalized both for mothers who are under threat of CPS and criminalized for midwives like myself who are under constant threat of, essentially being reported for for providing care that no one else will actually provide. Right, so then we're creating the circumstances where now women, what are their options? Give birth at home alone, right? Or go and try to find an obstetrician who will not support their VBAC or who will try to section them when maybe they're not a great surgical candidate to begin with. Maybe they're a poor C-section candidate because they have previous sections, maybe they have this history of complications, but there's actually not a provider for them, right? So this is what we've actually created within our contemporary midwifery culture. And then so often where we're actually struggling is then our conversation is then legislative. Then we're really over here being like, well, what's the answer? What's the answer? Is it more licensed midwifery? Is it more OBs? Is it more, Like, where do we actually like hone in? What's the legislation? And I just want to zoom us out back to the relational model. Let's name back to like the problem really, which where I see this problem is a breakdown of relationship. We're not actually in relational care, which has been a theme of our entire day. We need to be looking at this woman. We need to be looking at this baby. We need to be looking at this circumstance, her medical history. And while the problem is large scale, I would not say that the solution specifically for birth attendance is a large scale solution. And where does that bring us as professionals in women's health? How willing are we to be in the ethical, emotional, relational weeds of what it actually means to care for our communities, and to actually sit with the question that maybe our solutions can be informed. Like, I'm so grateful that MAHA invited me, that the Heritage Fund invited me to come and discuss this, because I work on a small scale. I work in my community. I have a broad amount of skills, right, that aren't super specialized. And to be here with all of these panelists that are hyper specialized, but then likely what's needed in our communities is someone, if I do say so myself, who has skills like, I can attend your vaginal birth. I can also help you with your breastfeeding. I can also likely assess your tongue ties. I can also do some body work for your baby. I can, do a little bit of cranial sacral. I can help you with your prolapse, right? And I can, maybe see you later when you're having incontinence, because no one brought into your biomechanics in, which I will leave out for today, but I'll plug those as well. But we actually need this return, I would say, to better skilled, more broadly skilled providers that are actually embedded within a community setting in women's health, right? That have this broad understanding, and we put them in a direct space to speak and be in relationship with patients. And that might not be scalable in the same way. This might be actually in the relationships that we have and in the conversations that we have. So how do we fund that? How do we actually choose that? Well, we become the people who are choosing time over financial considerations, right? We're here to critique it, but we need to be those providers, right? We need to be those people rather than just saying, oh, ACOG does this. And not that you're saying that, you're literally being this provider. But thank you, appreciate you. And so many of us here, where we're actually critiquing these large-scale systems and looking for this large-scale kind of legislative repair, which absolutely, thank goodness that there's so many of us that are working on a policy level. What an amazing policy success we had today in the Supreme Court. I'm not saying that there's not aspects of this, but can we be these providers in our communities? Can we be these advocates for women's health who actually make a different choice in how we relate to our ethics, our considerations, and our maternal fetal health care for the health of our mothers and our babies and our communities at large?
We really are at the end of the day, but if anyone wants to share some final closing thoughts, please do.
I just want to say I do have a handout about vitamin A and fetal development and the things that I said. And what we love in our foundation is to see the scientific validation of traditional food waste. And all of these things that traditional people did, the buildup of nutrition, the vitamin A-rich foods, and also the 3-year spacing between babies, I forgot to mention that, so the mother can recover her nutritional stores. These are all validated by modern science, and that's really exciting.
Oh, I don't have a short comment, so I'll just... Yeah, I mean, ultimately, again, if we wanted to change it on a macro scale, not on, because I agree with Adelaide, what she's saying is the relationship model, which is the traditional midwifery model, and the outcomes there are just better, and there's literature to support everything I'm saying, just as there's literature to support twin and breech vaginal birthing, and for whatever reason, ACOG and the medical schools and residencies are ignoring that sort of thing. But what they're doing is even worse than that. I mean, if you take a deep dive into the things that have been done in obstetrics, you find such lunacy. You find out these are supposed to be your experts. By the way, experts doesn't mean what we think it means. It's kind of like that from the Princess Bride, where he keeps saying inconceivable, and I don't think it means what you think it means, because I mean, for one thing, I just recently realized when one of my talks about, if you've heard of the labor curve, the Friedman curve. And if you remember your basic geometry, how do you draw a curve? It's dots on a curve. It's like an average. You'd have a scattergram, and you take the curve, and it goes through the middle of it. And I'm not even going to argue, I'm not even going to make a point, well, I will, that the points on this curve are vaginal exams, which are completely unnecessary for the most part. But what the Friedman curve is used for is if you fall off the Friedman curve as a woman laboring, then you're not moving fast enough. And you need to have your membranes ruptured, you need to start Pitocin, that's how the Friedman curve is used. But think about it again, the curve is the median, which means 50% of women are below the curve. And yet now they're considered abnormal by the medicalized birth model. You know, I could say the same thing about growth restriction, they've changed it to 10th%. Everything they seem to do seems to not improve outcomes, but generates more revenue. And that has to all change.
That has to. Can I have one other comment? Sure. Okay. So one additional factor that I just really, like, it's easy to kind of be up here and critique the way everything works, right? That's very popular. And I also want to add, okay, but what about boots on the ground? Like, what do we actually do when we leave here today? What about those of you that actually attend moms? What about those of you that are working in your communities as healthcare providers that care about this and trying to figure out what to do? The first thing I want to offer is if you are seeing women and they are pregnant, in your first visit, if you're an obstetrician, family med, whoever, in your first visit, can you actually ask this woman how she feels? And then can you tell her that, and give her some examples. Are you in pain? Do you have pain of this kind? Maybe this. I mean, not from this suggestive way, but actually being focused on her somatic experience of her pregnancy. And then introduce the idea that this is going to be something that's going to be followed up on every subsequent visit. This takes 2 minutes, and this is available for providers. And so then you cue her to say, I want you to pay attention. If you're short of breath, if you have pubic pain, if you have, round ligament pain, any of these more common things, right? To then say, will you tell me what that's like when you come back on that next visit? And actually ask her. If nothing else, we could use our time to actually be orienting women, and ideally, right? Then when she says, yes, I still have this pain, you send her to me and I'll help her with biomechanical solutions for these challenges, because so much of that really is an upstream solution for a lot of the complications that we actually see when babies aren't coming through the pelvic pathway. I'll leave that there rather than, kind of go into that topic, but this ability for us to demonstrate that women's sensory experience of their pregnancies matter, right? And that their attunement to their own sensory experience is an incredibly helpful skill for them to be developing during their pregnancy if we want better birth outcomes. We've been talking about body literacy today. We've been talking about how women knowing more about themselves is an essential component of improving our maternal fetal healthcare metrics. Right? So how do we actually do that in a patient visit? We inquire, we encourage, and we give her language, and we give her follow-up, and then we actually follow up, right? And ideally, if not in that visit, I'm not teaching every OB to do biomechanical and posture assessments, though I'd love to, right? Then we are able to provide other resources to actually address how she's feeling rather than simply normalizing every single discomfort and minimizing the canary in the coal mine that is our symptoms, right? Because that's also what we're talking about, in this broader restorative reproductive medical approach, is we ignore symptoms. Women are taught to ignore symptoms, and then we're not utilizing the information that those symptoms can provide to inform the better outcomes that we're allegedly trying to support, because we're not even naming the problem well. And a big aspect of this problem is women not actually having either the questions or the inquiry to feel into their own bodies, to develop their own understanding of what's going on, to be such informed, participants in their health and the health of their babies. So if you work with patients, just that, right? Just supporting that somatic awareness in a consistent and small way is an actionable step that we can all do to be better providers and care better for women and babies.
Thank you so much, Adelaide. Thank you, everyone, for coming. I hope that we have a little bit of time to be social afterwards.